Welcome to part one of Rapid Case Review, Management of Metastatic Urothelial Bladder Cancer. This is medical oncologist Dr. Neil Love. I met with Professor Yohann Loriot from the GU Oncology Group from the Gustave Roussy in Villesuif, France, who responded to cases presented by Drs. Fern Anari from the Fox Chase Cancer Center in Philadelphia, Pennsylvania, Dr. Jacqueline Brown from Emory University School of Medicine in Atlanta, Georgia, Dr. Nasli Disman from the University of Texas MD Anderson Cancer Center in Houston, Texas, and Dr. Catherine Fahey from the University of North Carolina Lindbergh Comprehensive Cancer Center in Chapel Hill, North Carolina. We begin with Dr. Brown, who has an older patient with a somewhat complicated past medical history.
This is a wonderful patient of mine. He's 80. He has a lot of medical problems, but is pretty fit. So he has a history of a renal transplant from his sister back in 2022. He's on an immunosuppressive regimen. He has Parkinson's, but he is very active. He walks 3 miles a day. He makes me feel kind of bad about myself when I hear how active he is. And he has a long-standing history of non-muscle invasive disease. He got various intravesical treatments and had a clean bladder on his last cysto when he developed this right inguinal and scrotal firmness. He had an MR which showed nothing, but you could feel it. He ended up getting a PET that showed all of this radiotracer uptake in that exact area. And his urologist did a transcutaneous punch biopsy in the firm area, and it came back showing plasmacytoid UC, which there would definitely been plasmacytoid variant in some of his prior samples from his non-muscle invasive disease. So very strange clinical presentation. He had no actionable targets. I had a long discussion with him about what to use first line. Of course, his renal transplant played into the decision for immunotherapy or not. We ultimately decided to not pursue immunotherapy, and I gave him EV monotherapy. He got 2 cycles. The end of the second cycle culminated in a rapid decline, fatigue, eye irritation, rash. He had neuropathy that was developing. He went in 2 months from a grade 0 to a grade 1.5 pretty quickly. At that point, he had clinical resolution. All of the firmness was gone. He showed back up to clinic. We had a long discussion of what are our goals here and how do we avoid getting you rehospitalized. I held the EV. This was almost 2 years ago now. I didn't intend to hold it this long, but I said, let's just see what your next scans show, and let's just see what your next scans show. And 2 years later, here we are. So he's had no evidence of recurrence. At this point, I just get CTs and MRIs. I'm not getting recurrent PETs, but he has no evidence of disease. We recently talked about, should we send circulating tumor DNA? And he and his wife are very savvy people. And they sort of said, Jackie, if you're not going to act on it, why would we send this? Which it was like they were medical school professors. And I said, yes, you're exactly right. Maybe we shouldn't send it. So I think questions for me on this case are, I think this doesn't just apply to a UC patient, but how do we think about checkpoint inhibition in any transplant patient? What the transplant is, how does that impact things, kidney versus liver versus cardiac, and then, of course, other autoimmune diseases. Another question would be, if someone is not a candidate for immunotherapy for whatever of those reasons that might apply, then in 2026, should I then do cisplatin doublet if I can't do EVP as my first line? Or do I do EV monotherapy? Obviously, for him, I had reasons to choose EV monotherapy, but I obviously don't really have a lot of head-to-head data in the first line setting of what somebody should get, cisplatin versus EV monotherapy. And then I just thought this was a fascinating presentation. Plasmacytoid, in the cases that I've had, it has sort of crawled along tissue planes very much like this and been very hard to image. And so when his biopsy came back showing that, I wasn't entirely surprised, but it's definitely made it harder to monitor him. We have a study open at Emory, which is looking at EV Pembro in true variants, and that will hopefully give us a little bit more data. But I'm not sure. 2 cycles with a CR that hasn't returned in almost 2 years is atypical. I've definitely seen it with EV monotherapy in the third line setting, but this has been very remarkable. And thank goodness, because he was up against a lot if I was going to keep treating him at that time.
So really incredible case. I have to admit, I've never even heard of plasmacytoid urothelial bladder cancer, but so many questions here. And I guess the first one, which you hear all the time in oncology in terms of contraindication to IO, when you talk about transplant, I've heard people say, well, theoretically, if they lose their kidney, they could get another kidney or go on dialysis. So first of all, any thoughts in terms of relative or absolute contraindications? Would you ever use an IO in somebody with a renal transplant if they were on board for doing that?
So, first of all, it's a very, very interesting clinical case, so very incredible. Coming back to your first question, in a renal transplant recipient, I would be very, very cautious with checkpoint blockade. I would usually avoid pembrolizumab or any other immune checkpoint inhibitors unless the patient accepts a real risk of graft rejection and dialysis. We don't have so much data. There is some reports using atezolizumab or durvalumab in this patient. They are higher risk to develop some complications. So it's feasible, but it's clearly a trade-off and a case-by-case discussion with the patient and nephrologist, clearly. So for this patient, EV monotherapy was a very reasonable choice, I think. He had a renal transplant, ongoing immunosuppression, creatine clearance around 50, I guess, Parkinson disease, and a very unusual but biopsy-proven plasmacytoid urothelial carcinoma presentation. So the benefit of adding pembro is clearly uncertain under immunosuppression, while the risk to the graft may be important. So clearly, I would avoid pembro here.
What about her question in terms of first-line therapy? If you're not going to use an IO, cisplatin doublet versus enfortumab alone?
So if a patient is not a candidate for immunotherapy, so I would say my decisions between the platinum chemotherapy and EV monotherapy depend on the reason they cannot receive immune checkpoint inhibitors, of course, and on neuropathy, renal function, and disease temporality. So if there are cisplatin eligible, I would still consider gem cisplatin, especially in a fit patient with no neuropathy. But if they are cisplatin ineligible but carbo eligible, gem carbo remains, I think, reasonable in 2026. But EV clearly monotherapy is attractive, especially if rapid and quick response is needed because the patient has some painful metastasis or high tumor burden, or if chemotherapy tolerance is uncertain. For example, if there is any baseline neuropathy, frailty, or like this patient renal transplant, clearly EV monotherapy to me may be more practical than platinum.
So what about the potential? I didn't really even ask Dr. Brown this, whether she thought about local therapy. It looks like this patient's recurrent or disease was localized. Could you imagine a situation where you might use surgery or radiation or, cryotherapy?
Absolutely. That's something we are discussing quite frequently in a multidisciplinary board. So if the patient is clearly unfit for immunotherapy, for chemotherapy or EV, or if the patient has a slow-growing disease, for example, with a very low tumor burden, that's something we can consider. Of course, if the patient has liver mets, a lot of lung mets, it will be tricky to provide this patient local treatment. But clearly for lymph node-only disease, for example, that's something we can consider clearly.
So another thing that I was thinking about related to this case is, EV pembro has really revolutionized the management of this disease. And
yes,
in this situation with the transplant is very, very challenging. But as she alluded to, there are many other situations where people have prior autoimmune disease. A lot of times I hear people saying that they will consider an IO in a patient like that if, for example, they're not on any specific therapy or they've done well. But it also gets into what the potential benefit of EV pembro is, particularly in terms of our prior available therapies, particularly cisplatin-based chemotherapy. And I'm curious to what extent we are seeing a tail on the curve with EV pembro.
Yes.
When you start people with metastatic disease with EV pembro, is one of your goals cure?
So, of course, we don't know. The follow-up is not long enough to know whether we can cure some patient. I do think that we can cure some patient. I have some patient in my clinics that has been treated with EV Pembro in the trials on EV302. We stopped both drugs because the patient was so fed up with numbers of visits, and there is nothing. So no metastasis on CT scan, and the patient stopped the treatment more than 2 or 3 years, and still the patient has no disease progression. So again, it's maybe too short, but I think we can cure some patient. The last update of the EV302 with longer follow-up show clearly that we can reach a plateau, as you mentioned, and probably, at least for the patient with lymph node-only disease or low tumor burden, we will see some patient that truly cure with EV Pembro, clearly.
Any comments on sort of the biology or synergy with immunotherapy and an ADC, antibody drug conjugate? This is such a dramatic example, but also in breast cancer, currently metastatic triple-negative breast cancer, first-line therapy is an IO and ADC, sacituzumab and pembrolizumab right now. Any comments on the thinking about synergy and maybe why ADC would be better than regular chemotherapy with an IO?
So we don't know exactly why. So if we focus on bladder cancer, for example, there is some example where there is no synergy at all. So like SG, so sacituzumab and immunotherapy in bladder cancer, fail actually to show any added value of immunotherapy. So there is a lot of hypotheses, and one explanation is that we can induce more immunogenic death, cell death, with ADC. So probably we can activate a bit more the immune system compared to the conventional, the old chemotherapy. But we need data, we need the on-treatment biopsy just to explore this question. But as of today, we don't have so many data to explain this, at least additivity and maybe synergy.
So this next case by Dr. Fahey is, I think I've heard about 50 cases as part of this series. And this next case is maybe my favorite one. Not only is it interesting, I find it personally very inspiring. And this patient, to me, is almost like my hero personally, I have to say. And it brings up the issue of, the good parts of oncology and how sometimes our patients really inspire us. Anyhow, this is a 92-year-old man.
He has an excellent performance status. He is still actively working. And so after discussion, he opted to start treatment with enfortumab vedotin and pembrolizumab for palliative management. This gentleman was 92. So when we started enfortumab vedotin and pembrolizumab, we started at the 1 milligram per kilogram dose. So a question for our faculty is, do you do any empiric dose reductions for patients based on age, comorbidity, or performance status? Or do you start everyone at the 1.25 milligram per kilogram dose? As far as toleration, we started him at that dose, and he did very well. Cycles 1 through 4, he really reported minimal toxicity. And then when he came in for cycle 5, he reported that he was having some difficulty with moving. And then when he came in for cycle 7, his neuropathy had continued to progress, so we did end up stopping the enfortumab vedotin at that time. He continued on the pembrolizumab with no toxicities. Unfortunately, though, scans after cycle 13 did show local progression in the bladder, so we ultimately discontinued his therapy at that point.
What's the current status of this patient?
I mentioned that I have a patient that I'm going to talk to about TDXT. It's actually him. So
wow.
He's still doing
Really?
great. I don't know if he'll do it, and I don't know that I want him to do it. I kind of think that hospice will be my recommendation, but if he really wants to do something, we can consider TDXT, but it's been wild. He's crushes it.
He's doing well?
Yeah, he's just doing really well.
He sounds like a pretty hardy 92-year-old.
Yeah, he really is. I remember reading his chart before I walked in, and I was pretty convinced I wasn't going to be treating him. And then talking to him, he goes to work every single day. Every week he comes in and asks me if he should retire, and I tell him he should do whatever makes him happy. And so he just keeps working.
Any questions for the faculty?
For this patient, he has an excellent performance status, so we did give him enfortumab vedotin and pembrolizumab, but most 92-year-olds would not be able to tolerate this therapy. Do you ever consider either enfortumab vedotin monotherapy or pembrolizumab monotherapy for a patient like that? And what would sway you to pick one versus the other?
Any thoughts?
For a 90-year-old patient, I think the most important point is that the chronologic age alone is not the decision maker, of course. This patient is in usual excellent performance status, still working, motivated for treatment. And so in that situation, EV Pembro makes sense. But I would be very proactive with dose modification because the therapeutic windows is narrow. So the patient started EV Pembro at reduced EV dose, but developed neuropathy by cycle 5, and finally EV was stopped. So in general, for a very elderly patient like this patient, I ask 3 questions. So do I need a rapid tumor response? Number 2, is the patient likely to tolerate EV toxicity, so neuropathy, rash, fatigue, anorexia? And number 3, is the patient likely to tolerate immune toxicity and steroid if needed? So when I would choose EV monotherapy alone, so if I need a rapid response, or if the patient has bulky, symptomatic, locally progressive disease, or like bleeding, obstruction, hydronephrosis, because here I'm worried that Pembro may add unnecessary immune toxicity. So, and why? Because EV monotherapy is attractive. We have a relatively high response rate, and response can occur quickly. In the phase 1, so the EV103 cohort K, first-line EV monotherapy in cis-ineligible patients, had an objective response rate around 45%. So compared to the about 65% with EV Pembro. So in this patient with frailty, autoimmune history, need to avoid steroid, I would consider EV alone. So, and when I would choose Pembro monotherapy, so you know that it's not the standard of care anymore, but I would consider Pembro alone in a patient where the main goal is to offer, I would say, a lower intensity treatment with the possibility of durable benefit. So especially with the patient with low tumor burden, so lymph node only disease, if the symptoms are minimal, or if the patient is very vulnerable to EV toxicity. Because Pembro monotherapy has a lower response rate than EV-based therapy. If we go back to the Keynote 052, first-line Pembro in cis-eligible patients, the overall response rate was about 30%. So, and a minority of patients achieve complete response, but the response could be durable. So, what would push me toward Pembro alone? Low-volume disease, lymph node-only disease, pre-existing comorbidities, so neuropathy, high frailty, and if the patient prioritize quality of life over response probability. So again, it's a case-by-case discussion here.
What about PD-1 level?
Now, PD-1 level is a big problem in bladder cancer. So the correlation with the outcome is a mess. There is a lot of issue and problem with PD-L1 in bladder cancer. So we don't use PD-L1 anymore in metastasis setting.
So as you heard, this patient also is HER2 positive, IHC3+. Yes. I was just flashing back to San Antonio Breast Cancer Symposium. We had a case presented of a 103-year-old woman with metastatic disease who actually wanted to be treated and was treated. But what about TDXD in elderly patients? He doesn't seem to have any relevant comorbidities. Any thoughts about that?
So we know that trastuzumab deruxtecan can be active in bladder cancer. There is phase 2 trials that show that response rate could be more or less 50%. So that's something we can consider. But again, here the payload is different. It's topo-1 inhibitor, so you can expect some toxicity like diarrhea, neutropenia. So probably quite problematic in all patients with some comorbidity. So I would be very, very cautious here.
So we've been hearing a lot of excitement about TKIs and HER2 mutant disease mainly, but also I think interest with overexpression in lung cancer with TKIs like zongertinib and sebabertinib. Are these agents, and also you have zanidatamab, a bispecific that's out there for HER2. I think in bladder also there's a tisotumab vedotin that's being looked at. Any of these other anti-HER strategies that you might think about, particularly in an elderly patient, maybe might be, safer maybe than TDXD?
It would be difficult because the TKI are not very active in bladder cancer. So the TKI targeting HER2, so either amplification or mutation. There is now some clinical trial that assess bispecific antibodies targeting HER2, but they are assessed in clinical trial, so limited sample size, and especially for bladder cancer. As you know, the bispecific antibodies could be active, but also are associated with some toxicity and CRS, for example. And of course, when the patient is 92, could be more problematic because you need steroid. It could be very, very serious. So unfortunately, if the patient is not fit enough for ADC and special trastuzumab deruxtecan, there is no specific therapy that target HER2 nowadays in bladder cancer.
What about discontinued vedotin?
So discontinued vedotin has been assessed in China with a positive phase 2 trial in first line, combinations with toripalimab, so PD-1 inhibitors. But we have also two other important trials. So one in first line, combining discontinued and pembro, and we are waiting for the data. And we have also a phase 2 trial in first line or in second line, and there is some activities. We've just seen the data, so a couple of months ago at ASCO GU, so early this year. So, but we have to wait for the phase 2 trial to know where the drug could be located in the algorithm in bladder cancer.
So here's the last case, a 59-year-old woman cared for by Dr. Anari, who was previously treated with neoadjuvant chemotherapy, radical cystectomy, and adjuvant nivolumab, and developed metastatic disease a year later, but actually responded to first-line EV pembro.
She started enfortumab vedotin and pembrolizumab on a de-escalation trial that we're running at our cancer center to help mitigate the adverse effects of enfortumab vedotin. She did develop some diarrhea after cycle 1 that was controllable with Imodium and felt to be temporally related to chemotherapy as it didn't persist throughout the entire cycle. She also developed itching after showers without evidence of rash, and she managed this with antihistamines before bed and moisturizing her skin. Her CT scan showed decrease in size of retroperitoneal lymphadenopathy with no new evidence of disease. Starting cycle 7, we opted to discontinue day 8 of enfortumab vedotin to mitigate some adverse effects such as progressive fatigue, pruritus, as well as diarrhea. She's been maintained on enfortumab vedotin day 1 and pembrolizumab of an every 3-week cycle. And at this point, she's received 23 cycles thus far. In patients who received adjuvant immunotherapy, who would you consider retreating with immunotherapy in terms of using first-line enfortumab vedotin and pembrolizumab versus enfortumab vedotin alone at the time of metastatic disease? Is there a certain time threshold since completing immunotherapy you use to help guide decision-making? This patient was treated initially back in 2022 and 2023 for her muscle-invasive disease. Given the data presented at ESMO 2025, how are you utilizing ctDNA in the postoperative setting, and how are you utilizing that to help guide adjuvant therapy?
So this patient actually ended up with recurrence about a year after receiving adjuvant nivolumab, and you can hear what happened with the enfortumab pembrolizumab. Any comments on this case?
So it's an important question that we have in daily practice. So a lot of patients are receiving an adjuvant immunotherapy, and unfortunately, some of them have disease relapse. And as you know, the EV pembro is the standard of care in first-line setting. But in the context of prior treatment with immunotherapy, we don't know how to proceed with this patient. So it's a very relevant question that we have here in this clinical case.
Any comments on the patient's course? So she did have some, as most people do, toxicity thought to be mainly from the enfortumab, fatigue, pruritus, a little bit of diarrhea. What's your experience? This is a younger patient. What's your experience in general? This patient was only 59 years old. Many patients are much older than that. What's your experience with toxicity, and how do you approach the issue of dose reduction with EV Pembro?
So usually EV Pembro is a well-tolerated combination well-tolerated in young patients and in old patients actually. To my experience, it's better tolerated compared to chemotherapy, but of course we can face some toxic effects. The most frequent adverse events from EV are really manageable. It's mainly neuropathy, ocular toxicity, for example. The main problem in the skin tox, we don't have any predictive factors, so it could depend in young patients, in old patients. And so we have to be cautious when patients develop grade 1 wash, for example, during the first month, because we know that this patient could develop a very serious skin effect. But usually, EV Pembro is well tolerated. And of course, in patients with some autoimmune disease, we have to be very careful.
So what about her question? These cases are all metastatic disease, but of course one of the biggest developments in the field has been the evolution of EV Pembro in the neoadjuvant setting. But what about this issue that she brings up of ctDNA that's been looked at now with immunotherapy and trying to incorporate that into the treatment algorithm? What are your thoughts about that? Is that something that you're doing right now?
So I increasingly view ctDNA as a strong prognostic and now potentially treating guiding tool with the MVIGO-011 that showed that ctDNA guiding adjuvant atezolizumab improved DFS and overall survival in ctDNA positive patients after surgery. The Checkmate 274 with nivolumab also supports the long-term benefit of adjuvant nivolumab. And with ctDNA analysis adding some, I would say, biological plausibility. But practically, I would not send ctDNA unless I can act on it. So, of course, intensify follow-up, enroll in clinical trial, or select adjuvant therapy. And as you mentioned, now EV Pembro is a standard of care in cis-eligible patients and probably in the future, in the near future, in cis-eligible patients. So we don't know how useful is ctDNA after the cystectomy because it was proven mainly in patients not treated with EV Pembro, but just treated with surgery and chemotherapy to guide the treatment for the adjuvant treatment. So here we don't know. With EV Pembro, we don't have any data so far. Probably we will have in the coming months. But data are lacking here, and we need clearly prospective data, clearly.
Subsequent to the recording of this program, the FDA approved pembrolizumab in combination with enfortumab vedotin as neoadjuvant and adjuvant therapy for adults with muscle-invasive bladder cancer undergoing cystectomy. This concludes our program. Note that the use of agents and treatments that are not approved may be discussed in this program, so check out the package inserts for more information. Special thanks to Professor Loriot and the case presenters, and thank you for tuning in. This is Dr. Neil Love for a Rapid Case Review.